Okay. Welcome today to the 7-day ECG flashcard challenge. Today's flashcard on the was talking about myocardial infarction, and we're talking about STEMI criteria, how to spot the real attack. And then we did mention on the flashcard that the criteria to remember is that if you have it in more than two contiguous leads. Now, for those who do not know, contiguous leads mean that leads that signify the same area of the heart. For example, if you look at the way leads are arranged, and again, when I do these PowerPoint presentations, I've done a pre-challenge survey to get where you are at and what you need. But if, however, you listen to any of this and you think that there's something that needs more explanation based on that topic, I'm happy to revisit it because that's the whole idea to make sure that ECGs become less intimidating for you. And for some of you, this is probably something you know. I always like to say that, I do this for all classes of people, and many times I start from simple to complex. And there are other courses that deal with more advanced ECG topics. So moving forward, um, let's just go into it. So the way I like to do it is I like to follow when you hand me an ECG in the emergency department. I like to use the emergency department because I work a lot there, and it can be fast paced there because many people come there because they indeed have an emergency. Some other people do not have a real emergency, but they do not know. They're scared that they have an emergency. So you're given this ECG and you're expected to quickly look at it, make a quick decision. Many times there's this pressure to just deliver a verdict or tell your colleagues what you need them to do. And on the other hand, there's this internal fear of, oh, I don't want to miss something so big like a heart attack or miss ST elevation, MI equivalent. And that pressure can be real. So I believe that that could be the reason why you are taking this course. So if you hand me an ECG, and I'm trying to be a bit more thorough because nowadays, I mean, in the beginning, of course, I would follow like a rigid formula, but nowadays it comes natural to me that it doesn't even feel like I'm following any steps, and I'm still being thorough. So you look at your rate, rhythm, regularity, axis, intervals, injury, and then the context. And when I'm done with that, I want to look at the five zones of the heart. So I like to divide it into this in my head. So it's like two L's. So one is an upright L, is an inverted L. Then whatever is left form small boxes and squares like you can see. I will annotate as necessary, only very well when necessary. I'm working on getting a software that helps me to annotate easily, but it can be a bit tricky on the laptop. So, but you can see how it is divided here. And so I quickly do a small L, an inverted L, and the others fall into squares. And this first L for me, which contains 2, 3, and AVF, they remind me that this is the inferior, this is the inferior part of the heart, and that the right coronary artery supplies this area. So contiguous leads, like you see in the flashcard, when they say it must be in at least your ST elevation must be in at least two contiguous leads, means that it has to be. If you're telling me that you're seeing ST elevation in two, of course, in any ST elevation, I'm going to bat an eyelid. I'm going to look at it a second time. So in any elevation, I'm going to look at it a second time, but it's more likely to be a serious thing when it is appearing in two contiguous leads. So if I have it in 2 and 3, for instance, I'm having it in 3 and AVF, there's more likely something is going on there. Now, for V1, V2, V3, and V4, they supply the anterior aspect of the heart, the anterior septal part of that, because many times the septum, the same blood supply that goes to the septum goes to the anterior part of the heart. I said many times that's how the anatomy of the heart is, and that's supplied by the left anterior descending artery. Then you have the lateral STEMI, which you comprises of your 1 AVL, V5, and V6. I like to put a drawing of the heart somewhere here if it's not on the slides, but it just shows you how the leads are arranged and how they look at the heart, and that is what informs us saying, oh, 2-3 AVF is inferior, because the way 2-3 AVF leads are placed, they visualize the inferior part of the heart, and when the abnormalities there, or for example when you have a problem with the axis, it shows, for example, if the left heart is, if the there's left ventricular hypertrophy and the signal is being blocked away, or you get that in your ECG. You see that in your ECG. So everything has a basis. Um yes, everything does have a basis, and the way the leads are arranged, if you can visualize that picture, and I'll see if I can pull that up as well, will help you to know the basis of saying, oh, this looks at the anterior part of the heart, and if this looks at the anterior part of the heart, then we know that is the left anterior descending artery that is supplying it. Okay, I do have it, no, but this is not the exact picture I did have in mind. But as you can see, the right coronary artery, the left main coronary artery, the anterior descent. So the right coronary artery, you can see that it is supplying the inferior part of the heart. So you've placed your leads 2, 3, and AVF. And I mean, you are reading off that ECG, but that's because the 2, 3 AVF have been positioned in such a way by the technicians to view that inferior part of the heart, which is supplied by the right coronary artery. Now, the anterior descending artery of the left coronary artery, that supplies the anterior wall of the left ventricle, and that's the front to third of the septum. The left circumflex branch of the left coronary artery will supply the ilateral wall of the left coronary of the left ventricle. Now, why is this important? Again, I've said if you are noticing an ST elevation in any of these areas and you're thinking of a myocardial infarction, you're thinking of which of these vessels are blocked. Which of these vessels have, succumbed, have been occluded by, have had atherosclerosis, have been occluded by a thrombus or a clot. Which of them, and we talk about, is it 100% occluded, 95% occluded? By the time they go for cath lab and to the cath lab and they're having their PCI, they're able to detect this. But this already gives you a clue as to where the problem is and what needs to be done. So, this is a more detailed picture. I will skip this for the sake of this challenge, because what you need to know with any ECG, with the basics of an ECG, is how to identify an MI. And so we've talked about this. The left anterior descending artery supplies the following areas: the anterior wall of the left ventricle, the apex, the lower part of the lateral left ventricle, the anterior two-third of the ventricular septum. Now, the left circumflex artery would supply the left atrium, the upper part of the lateral wall, the posterior left ventricle, and inferior left ventricle um, in 2-3 AVF in 15% of the time of individuals. The right coronary artery supplies the right atrium, and ventrally the entire right ventricle, the posterior one-third of the ventricular septum, posterior inferior left ventricle. Now, um, the blood supply to the conducting system, the SA node, the right coronary artery will supply 75%, dual in 25%. You can look at this. Now, again, I really think this is basic. It's not basic, but it's anatomy that we probably have read somewhere and forgotten. And if you are a cardiologist or you're an intensivist, this might be this might be something you really want to think about. But the most important thing I like to tell for a lot of people that are just trying to get away with the basics of an ischemic heart disease, identifying an ischemic heart disease, is that you need to know what your LEDs 2, 3 AVFs mean. If you have an ST elevation or you have changes, ischemic changes in your 1 AVL, V5, V6, what does that mean? And if you have changes in your V1, V2, V3, V4, when do you get concerned? And that is what I will be dealing with. Um, 2 seconds, please. Just got to get this drink away from here. Okay. Yes, thanks for your patience. So, in summary, the left coronary artery supplies most of the left ventricle and the left atrium, and the conducting system or below the atrioventricular node. It can contribute to supplying the sinoatrial and atrioventricular node. And now this is important because if the sinoatrial node is dead from being supplied, what would you find on an ECG? If the atrioventricular node is diseased from myocardial infarction, this would affect the conduction of the heart, wouldn't it? And that's one of the reasons why we are very worried about it being impacted because the conduction system of the heart is messed up. They can have arrhythmias quickly. They can run into ventricular fibrillation, and that is what you're trying to avoid. The right coronary artery supplies the right ventricle and the right atrium, the inferior and posterior left ventricle in 85% of the population, the sinoatrial and the atrioventricular nodes, and it contributes to the conducting system below the atrioventricular node. Now I'm going to skip by this because I want to get to the basics. Now, the first thing to appear on an ECG when somebody has a heart attack or is having ischemic changes in the heart, not necessarily just in a heart attack, just ischemic changes in the heart. The first thing in the first 5 minutes that you find is you find hyperacute T wave changes. And we talked about the different waves and what they mean. And these changes can occur in less than 5 minutes from the person having the ischemic changes, and it can resolve in hours. The next thing that you would see after an hyperacute T wave change is an ST elevation. Now, the ST elevation would occur typically within 20 minutes and can be up for about hours to 3 days. Now, you start having a terminal portion QRS changes in hours, but your Q wave usually signifies an old MI, and by old MI we mean 9 hours to 2 days. It can be permanent. So I've seen a lot of patients that I find Q waves in, and when I check their previous ECGs from 4, 5, 6 years ago, 7 years ago, I discovered they had the same Q wave because they've had a heart attack, and it can signal you to a missed heart attack as well. Now, T wave inversion can be variable in onset and it can resolve in onset. So T wave inversion is, I always like to look at my T wave in majority of cases because they can signal to you whether there was a heart attack, there's a current heart attack. So it's really variable in the sense that it might not tell you about the timing, but can tell you that something is going on there. Now, and this is what we've described. Now we look at these waves properly. You can see how the normal one is, and when you have an acute one, you begin to have like hyperacute T waves. Then you have a proper ST elevation, and you can see that the R wave is becoming small. Is becoming less. Yes, the R wave is becoming a bit less prominent, but I would think it's becoming the R wave. So what we talk about in terms of R wave is that when you have poor R progression, then what you will get is what if is an old MI. So if you see a poor R progression, then that is probably into you at an old MI. But what you will see here is that the Q wave becomes deeper. So the R wave becomes smaller and smaller. The Q wave becomes deep, it becomes a bit more deep. And what you see weeks later is you can find that your ST and T wave have come back to normal, but your Q wave persists. Now, the location of the myocardial infarct, we've dwelt on this. What I like to say, what I like to explain with the issue of the myocardial infarction is that you just have to know the basics as a doctor, whether you are whatever you do, but especially, of course, if you work in emergency, whether you're a dermatologist or you are whatever it is, the first thing is you need to many times in the emergency department where I work in the United Kingdom, what you might not be the person to see the patient first. They've been triaged to you by your clinician colleagues, or sometimes the first inkling that you have is the ECG. So many cases, I have not seen the patient before the ECG. I see the ECG before the patient, and no matter what it is, whether it's a normal ECG or whether I see features of a heart attack on the ECG, it always follows with the question, how is my patient, like I've explained. And if it tells me if there's a history or clinical assessment suggestive of an acute coronary syndrome, I want to check the ECG one more time. Now, is the STX segment elevated or is there a new left bundle branch block? And if there is, that is an MI, ST elevation myocardial infarction. Now, at that point, it could be a benign early repolarization, it could be an ST elevation mimic, it could be something else. But especially if the history is suggestive to me, if they are elderly, if they have cardiovascular risk factors, a lot of this I may not be able to get by just saying, how is my patient? But sometimes they say, oh, the patient is having some pain, then I know there's a problem. But my point is that you want to see if there's ST elevation of any kind in contiguous leads or not. Better if it is in contiguous, I mean, it's not better, but more suggestive of an MI if it is in contiguous leads. Now, if you do a 12 lead ECG and there's a normal ECG or there are other ECG changes that you're not sure of. Maybe there's no ST elevation, maybe there's ST depression, T wave inversions, 4-hour progression, Q wave, even a Q wave. You now want to check your troponins, even though you have a normal ECG. And if troponins are present, then you know that there is a non-ST elevation MI going on because it does not place your patient in the clear. Your troponins come back and then you see, oh, maybe the ST is not elevated, but the troponins are, so this is most likely an NSTEMI. But if the troponins are consistently negative, say they had the chest pain within in the last 4 to 6 hours or even the same day, and you did it a couple of times based on your clinical reasoning, and the troponin is not increasing, then you may reconsider other causes of chest pain. But bear it in mind that you may be dealing with unstable angina. And it's higher risk non-S elevation angina, if non-S elevation acute coronary syndrome, if there's ST segment depression, if the ECG changes, if they keep changing, like you see one, it's not looking like the next one you do in a couple of hours. And if there's an unstable rhythm, if they have diabetes, it can really, a lot of people with diabetes do have silent MI where they come in and what they have is breathlessness or they have something else or they are unwell. And then you discover at the end of the day by incidentally doing troponins or by seeing an incidental finding on an ECG that indeed they were having a heart attack. So we've gone over this table about what supplies what. The left circumflex artery or the right coronary artery will supply 2,3 AVF. The left anterior descending will supply the anterior aspect, anteroseptal aspect of the heart. The lateral part of the heart will be supplied by the left circumflex or the diagonal branch of the left anterior descending artery. And this is what we have discussed. Now, I've not talked about posterior MI. In posterior MI, what you will have is depression, ST depression in V1 to V4. It's really quite funny because instead of having an ST elevation, you think, oh, this is a non-ST elevation MI. But indeed, if you do take your leads in V4 to V6 and you put them at the back, V7 to V9, what you will find is that there is an ST elevation, and that will be significant of a posterior MI. Posterior MI often occurs a lot of times in tandem with inferior MIs. Now, the shape of the ST elevation matters. The ST elevation can be plateau-shaped, dome-shaped, oblique-shaped, looking like a tombstone, as you can see here. But the anterior, yes, I was talking about the anterior STEMI. It results from the occlusion. Now, I think yesterday I did discuss SC elevation mimics in passing, for example, and I did talk about the J point and the J wave, how the J point is what we use to check whether there is conformity to the isoelectric line. Now, I may be saying all this and it may be sounding like jargons to one or two of you, but it's really quite simple. And it's just a pity. I did a video, but I'm not sure if there's any points that you think fine, but that you do not know, and I've mentioned, and you would like me to elaborate based on this topic, please send a message. I want us to maximize the 7 days of interaction to get the best of it. Now, we've gone through this. When we've said anterior MI carries the worst prognosis of all infarct locations because of the large infarct size that occurs, the left anterior descending artery supplies quite a large portion of the heart, right? Now, we often talk about reciprocal changes, and I believe it's on the flashcard. One clue as to the fact that this could be an ST elevation MI is that you get reciprocal ST changes. Now, if you look at the way the leads are placed, right, you see that um, in the opposite parts of the art where you're having where you're having the ST elevation, you will have ST depression because the other leads are looking at the other side of the heart, opposite where you're finding the ST elevation, and that will be another inkling. In men, if you have ST elevation greater than 2, that should prompt you as to this could be a myocardial infarction. And if you have it greater than, they'll say greater than 2 in chest leads, greater than 1 in the limb leads. No question is silly. Do send me a private message if you're having any issues, or you could put it on the group so that others would learn. And yep. So this is an anterior STEMI. Now, how do you know this is an anterior STEMI? I think this is the time to annotate. Now, let's assume I was given this ECG. And I quickly looked at the ECG and I said, ideally, to be fair, if I was given this ECG today now, I know that I would pick up the ST elevation quickly. And I know that if for even anybody that is not very conversant with ECGs or doesn't really do ECGs on a day-to-day basis, they will look at this T wave and say this is definitely abnormal. But let's say you wanted to go through the system rate, rhythm, you check the rate. Rate is just grossly less than 100, just below 100 beats per minute. The rhythm looks like a normal sinus rhythm because it's a P wave following every QRS wave. It looks quite regular. The rhythm, the P wave is upright in leads 2, it's upright in leads 3, it's inverted in AVR as it should be. So that's fine. I'm okay with that. But the intervals, what are the intervals telling me? The PR interval does not look prolonged. The QT interval does not look prolonged. I'm seeing what looks like an extra wave after the PQRS in lead 3, after the third wave. But that's fine. I mean, it might not be fine, but right now, bear it in mind that I'm looking for an emergency. I will still go back and dissect it in detail if this is not an emergency. But noted. Now, the intervals, the QT interval doesn't look too bad. The QRS looks narrow, complex, except in, let's see, it's still narrow, complex, but quite tall, and quite negative. And then what I can see, I'm just going to move my cursor a bit. What I can see also is there is the R wave progression isn't too impressive. Well, it's not too impressive, but let's go to the meat of the matter. We've talked about intervals. What are the signs of an injury? That's the signs of an injury. We've talked about the fact that you would have hyperacute T waves, you would have ST elevation, you could have ST depression, you could have T wave inversion, you could have Q waves. So in this regard, we can see here in V2, in especially in V2, we could see that the ST elevation is by at least one, two, three, by about 4 small boxes, right? Now, this is the J point I was talking to you about. This is the J point. No, that isn't it. Please forgive me, I lied. But this is the J point. Now, the J point is obscured here, but the J point is that point where it goes to join the T, and ideally it should be at the same level as the isoelectric line. So if you look at your J point, and in this case you can see the J point is elevated here. This is, and it is by more than this is about 1, 2 boxes. This is an ST elevation MI, and you can see that the T waves are very tall, right? Yeah, quite tall, aren't they? And there are at least more than 5 small boxes. This is, and when you now look at at 2, if you take a good look at 2, 3, you'll find some degree of ST depression in these leads, right? Now, and that is confirming to you that this is more likely than not to be an ST elevation MI. I would call the cath lab. Now, I would activate the cath lab. Now, inferior ST MI, these are the most common MIs. We've said the anterior ones are the most dangerous because they cover a large portion, but these are the most common MIs that you will find in practice. Now, how to recognize an inferior ST elevation MI? The ST elevation in leads 2, 3, and AVF, and there's progressive development of Q waves in 2, 3, and AVF. There's reciprocal ST depression. Remember what I said about reciprocal ST changes? If you have ST elevation in 2, 3 AVF, you will have ST depression in 1 VL and 1 V1 and V2. And the vast majority of inferior ST elevation MIs are due to dominant right coronary artery occlusion. Now, in this is an inferior ST elevation MI, and how do we know? We know that the ST is elevated in there is hyperacute T waves in 2, to be fair. There is some ST elevation, but it's not as clear as what you will find in 3. And in AVF, you can see how hyperacute the T waves are as well, even if you're not able to appreciate the ST elevation as much, because what you have as a criteria is greater than 1 small box in the limb leads and 2 in the chest. So all you need is for it to go above it by 1 box, and then you have your ST elevation. I'm trying so hard to draw the isoelectric line so that you can appreciate the ST elevation. The ST elevation is most prominent in 3, but you still have it in 2, I would argue, and you have ST depression, reciprocal changes in AVL, you have reciprocal changes in V2 and in V3. So this is what we're talking about. This is an inferior ST elevation MI. Now, in posterior MI, we've discussed this. This accompanies 15 to 20% of STMIs. It often occurs in the context of an inferior or lateral infarction. And the posterior extension of an inferior or lateral infarct tells you that there's a larger area of myocardial damage with increased risk of left ventricular dysfunction and death. So that's why it's important not to miss it. To be fair, if you're already having an inferior MI or a lateral MI, you will be activating the cath lab anyways, and they will discover the other arteries that may be affected. But sometimes it does occur in isolation. And when you're getting depression in your anterior leads, it should signal you to look further for a posterior MI. Now, it's suggested we talked about the fact that there's horizontal ST depression in V1 to V3, tall broad R waves greater than 30 milliseconds, as you can see. And there's upright T waves, dominant R wave, the R to S ratio is greater than 1 in V2. These are the criteria that you will find. Now, look at this ECG. What do you find? The first thing that may strike you is the fact that there is an inferior MI, and you may want to stop there. But look at V2, V3. Where you're expecting your reciprocal changes in inferior MI, you're expecting it in 1 AVL, 1 AVL, and maybe V2. But yeah, look at V2, V1, V2, V3. What you have is consistent ST depression. You would also note here that we said if the T waves are upright and if the R to S ratio is greater than 1, if you see the R-S ratio greater than 1, so in this case, this would alert you. And when you go here, you can see that the leads were rearranged V4, V5, V6 were placed at the back around the scapular region, and then you find out that there is indeed an ST elevation here, and this alerts you to the fact there's also a posterior MI and that there's a big territory infarct going on here. So in the right ventricular infarction, it can complicate up to 40% of inferior ST elevation MIs, just so you know. They are subtle and they are easily missed. And the first step to spotting it is to suspect it in all patients with inferior ST elevation. You might ask yourself, do they also have a right ventricular infarction? And the ST elevation in V1 is the only standard ECG that looks at the right ventricle. And if the ST elevation is greater than in 3 than it is greater than in 2, then you have to suspect it because leg 3 is more rightward facing than 2. I do not want to bore you with too many details. This is supposed to be a flashcard challenge for you to identify MIs, but suspect right ventricular infarction if you're seeing an inferior MI. Now, this is a right ventricular. As you can see, there's S elevation in V1, right? And when you get, in fact, it is so pronounced, and you would think that, oh, I should have S elevation in V2 as well. There is ST elevation in V2, there is in V3, but when you look at in 2 and 3, there's also ST elevation in 2 and 3. So this is looking quite odd because you're having ST elevation in 2, 3, V1, V2, V3, and you're having ST depression in V6. So it's looking quite like an inferior MI, quite like an anterior MI. However, what you will find here as well is that the ST elevation in lead 3 is greater than the ST elevation you find in lead 2, which would tell you that not only do you have an inferior MI here, the entire right ventricle, not the entire one, but at least the right ventricle is really being affected. And that's the same here. So we've talked about ST elevation MI. Now, the non-acute ST elevation MI compasses two things. So I always like to draw an algorithm, chest pain. Now, when they have a cardiac sounding chest pain, the it's just going to alert you to, is this an ST elevation or a non-ST elevation? That's what we call the acute coronary syndromes. Now, the ST elevation MI is on one end, and the other end you will have a non-ST elevation. Non-ST elevation can be an unstable angina or non-ST elevation myocardial infarction. So you have a STEMI on one hand, non-ST elevation acute coronary syndrome on the other hand. And the non-ST elevation acute coronary syndrome can be an unstable angina or an a non-ST elevation myocardial infarction. And in a non-ST elevation myocardial infarction, you will find ST depression, other changes. But in an unstable angina, your ECG may be normal. Now, there are too many ECG patterns that are associated with non-ST elevation, acute coronary syndrome. You could have T-wave flattening or inversion. You could have ST segment depression. Now, there are other less well-known ECG features of myocardial ischemia, and which is, for example, your U wave. We've talked about your U wave for yesterday's lecture, but if you also have a U wave, we like to say that your U wave can be significant of a right ventricular hypertrophy or a posterior MI, right? So it's just important that you also look out for your U wave. I believe we will stop here because the whole idea was to discuss myocardial infarction. I hope this was helpful for you. I do not also want to make this too long. Thank you.